Thank you very much. My name is Paul Kanyutu. I'm a Medtronic technical consultant here in Kenya. I was requested by Dr. Jaylan and Dr. Sheriff, and also my colleague Lynette, who is not feeling well, to assist with this presentation. And I'll gladly take you through basic cardiac device follow-up, focusing mainly on CRT, and some algorithms that are critical to help achieve alleviate heart failure in our patients. And in case of anything, in case I'm not audible enough, feel free to interrupt me at any point. Or in case you have a question or want to seek any clarification, I'm very open to just interrupt me. I'm okay with that. So our objectives is the systematic approach that we have for device follow-ups, focusing on CRTs. This is one acronym that we have for a basic follow-up of CRT device, PBL stop, starting with the presenting rhythm, the battery status, lead status, sensing, threshold, observation, program, and print, and then the summary. This helps you to make sure that you've covered all the basic things that you need to have a look at when assessing your patients, when assessing the device that your patient has. So I'll take an in-depth look at every of these. So in the presenting rhythm, mainly you look at the rhythm itself, the rates, and the percentage pacing. And like you can see in this photo, the Medtronic device allows you to see, this is the rate. I hope you can see my highlighter pen. Allows you to see the rates, allows you to see the presenting rhythm. In this case, you can see there's an annotation here, APVS, and allows you also to see the percentage pacing in this column. Percentage pacing of the ASVS, atrial sensed, ventricular sensed, atrial sensed, ventricular paced, atrial paced, ventricular sensed, and atrial paced, ventricular paced. So basically, this is the first thing that you look at, atrial paced, the presenting rhythm, with a focus on the rhythm, the rates, and the percentage pacing. So in most of our CRT devices, you realize we have the leadless ECG that allows you to it mimics the surface ECG with reference to CAN, the battery itself, to RV ring, or at times CAN to atrial ring, and you sort of have an ECG that is close to the surface ECG that we have. So after having a look at the presenting rhythm, the next thing that we look at is the battery status. In some of the old devices, I think the protected devices, the devices before 2015, they used to give you a percentage, they used to give you a voltage and could not give you estimated time in terms of years. But in the most recent devices, you're able to know the estimated time, estimated longevity of the device, and minimum consumption is going to take you this time, and a maximum consumption will take you this time. So based on the battery status, you're able to know when to recommend your patient for battery replacement based on RRT, ERI, or EOS. So RRT is the recommended replacement time. Usually it's 6 months towards the battery depletion. Then ERI is the elective replacement indicator. Usually it's 3 months to the battery depletion. And then end of service is when the device is not functioning entirely. So what really happens with EOS is loss of pacing or sensing, erratic pacing, or loss of the ability to deliver adequate therapy. And for you to be able to see this, to get this, the battery and lead measurement, the best place is, the place to find it is click on this icon here called data. And then below data, you're able to see the battery and lead measurement option. So in our recent devices, ICDs and CRTDs, you're able to see the longevity here, remaining longevity. And if you click on this echelon here, it's able to take you now to that page that shows you all those parameters, the time left, minimum and maximum longevity that you have. So when you click on that echelon, it takes you to this window that you're now able to see all those timelines and also see the battery voltage that is left. So after you're done with you've checked at your P, the present integrative, you've checked at your battery. The next thing you look at is the lead status, and you measure the lead in terms of the impedances that you have, where the normal pacing lead impedance should fall between 200 and 2000 for pacing leads, while for defibrillation should range between 20 to 200 ohms. And the good thing is that the Medtronic device gives you a graph indicating the threshold. And most of the times, if the threshold is within the normal range, you're going to have a very stable graph for impedances over the years, over the months. You're able to see the values here of the impedance as measured by the device, and you're able to see the trend over a couple of months or years of the device. So clicking on this echelon, you're able to have an in-depth analysis of every lead, atrial lead, RV lead, LV lead, and also the defib impedances. And it's key for you to make sure that you have a very stable, you have a very stable, you have a very consistent curve trend over the years. So at times you're able to see spikes on your lead impedance, like in this case. And this is an indication of a problem with your lead. So most of the times, a decrease in impedances, which is more than 30%, is an indication of a problem with the lead insulation. Whereas a spike, like in this case, by more than 30%, is an indication of a possible lead fracture or maybe fault with the connector. And this might end up affecting your sensing and thresholds. You might find that in case there's this spike in the impedances, you're going to have a similar, there's a possibility you're going to experience similar spike in threshold and sensing also. So the device itself is able to auto measure the impedance, but in case the patient is coming in for follow-up and you need to measure the lead impedance, on this icon where you have the params, you're able to click on this other icon called lead impedance, and you're able to do a manual test of, you're able to do a test of an in-office test of the thresholds. And with this, you're able to get impedance values for all the vectors. Like in case it's a quadrupolar device and you need to get impedances for all LV pacing vectors, this is going to sort you out with that. So this is an indication in case you want to include all LV polarities. You click there and then you click on this echelon here to get a value of all the measured lead polarities. Like you can see in this case, this is a display of all the measured lead polarities. So after you're done with the third acronym, which is the lead, the next thing is you look at the sensing. And sensing is the ability to see the intrinsic depolarization of either the atrium or the ventricle. And most of the times, the device itself is going to show you that. It's going to show you that you have a P wave of this value, or you have an R wave of this value. And you know, for CRT, it is very important for you to be having a very good atrial sensing to achieve good by V. And so sensing sensing of both the P wave and the R wave is quite very important. So in the Medtronic device, you can see where I have the highlighter, wave amplitude. You're able to see both the trend on this graph and the values of the atrial and RV sensing in this portion. So in this instance, you can see you have a P wave of 1.9 millivolts and a R wave of 16.3 millivolts, and you're able to see the trend over the years. Unlike in impedances, it's possible for you to see these spikes because the voltages in both the chambers really are fluctuating with time. So at times you're able to experience abnormal sensing measurements, which will arise from same things that cause a spike in the lead impedances, which could be insulation breaks, fracture, or maybe even the connector itself is having an issue. At times, when you have what you call electromagnetic interference, places with very high voltages, they could interfere with the sensing, or also the electrode placement. So for you to be able to test the sensing, some of the key things that you need to look at is the pacing mode that you are at, your lower rate, and AV delay. Since you want to unmask the intrinsic, you want to make sure that you are at a rate that is going to allow you to see the intrinsic of the patient. Usually for Medtronic devices, the lowest that you can go is 30 beats per minute. And here you're able to see this is the mode, this is the AV delay, and this is the lower rate. So in case a patient has a complete heart block, it might be difficult for you to be able to unmask the ventricular activity at this AV delay. So you can change the mode to VVI. And if you change the mode to VVI, you're going to eliminate the AV delay. And then you can lower your rate to maybe if the patient has a rate of 34. And at a rate of, make a lower rate of 30. And at that rate, you're able to unmask the intrinsics, both the PF and the RF. So the key thing is to make sure that your rate is lower than the patient rate. And also if it's a patient that has a heart block, you also have to make sure that the AV delay allows you to unmask the ventricular activity. So after you've done your sensing, the next critical thing is the threshold. This is the fifth acronym, the T. And threshold is the minimum amount of energy needed to consistently capture the heart. And threshold is critical as it guarantees you consistent capture, like the device will be functioning as it should. And also, based on the value of threshold, you're able to know the longevity, you're able to influence the longevity of the device. Lower threshold means that you can program your device to a lower output, and in return, you're able to have a longer, the battery is going to serve for a longer time, have a lower output, as compared to a time when you have very high thresholds, which are going to need you very high outputs, and in turn require you to deplete the battery very fast. So these are some of the acceptable atrial thresholds for both the atrium and the RV. At 0.5 milliseconds, this is the pulse width. And you'll notice the RV has the lowest acceptable threshold of 1.0 volts, atrial 1.5, and LV 3.0. Most of the times you find yourself with a threshold not so close to the atrial RV when you implant the LV lead. Any question? Okay. So the Medtronic device has the capture management, auto capture management, that does the automatic threshold checks once every day. And this auto capture management is what is the data that you're able to see on this trend. So it does the stimulation itself and gets to know what point the device loses capture, both in the atrium, in the RV, and in the LV. And the values that you see here are a result of the auto capture management. All the trends that you see here are as a result of the auto capture management. So when doing the manual test for the threshold, you still come to this icon of the test in this window, click on the threshold, and you're able to do the threshold test from here. Amplitude decrement, the chamber, the ventricle. You choose, you can choose DDT, you can choose VVI when you're testing the ventricle at a rate of 90. And then you can start at 2, you can start at 3 volts, 3.5, depending on, basically what guides you clearly is the data that you've seen in that quick look screen that has the auto capture management data. So when doing the threshold test, when using especially the amplitude auto decrement, how you get to know that you've lost capture is, for this case, let's say that you've been on amplitude auto decrement. So your amplitude is going down from 1.5 all the way down with a decrement of 0.25. And you realize for every pacing spike, there's a corresponding QRS. For every pacing spike here, there's a corresponding QRS. When you're on the 2090 Medtronic programmer, you'll see an annotation written VP, which shows you that at this point there's a pacing that there's a pulse that has been delivered. So you expect that when there is capture, for every pacing spike, there's a corresponding QRS. And then for this instance where my highlighter is, you'll notice there's a pacing spike. In the 2090 programmer, you're going to see an annotation written VP, but there's no corresponding QRS. And this tells you that at this point, a pulse has been delivered, but the pulse is not enough to cause an excitation of the heart muscles, heart tissues. And at this point is when you lose the capture. And so since you lost your capture at 0.5, at 0.5 you didn't capture consistently, then it's safe to say that your threshold is 0.75. Because threshold is that value where you have consistent capture, you're guaranteed a consistent capture of the myocardium. So based on this, the threshold itself guides you on now how you're going to adjust your programmed outputs, and the programmed output in terms of the amplitude and in terms also of the pulse width. And for Medtronic devices, they usually have a 2-time safety margin. So if you have a threshold of 0.75, the advisable output should be 2 times that threshold. So if you have a threshold of 0.75, the recommended or the safe output to have is 2 times of 0.75, which is 1.5. So programming 1.5 or 1.75 or 2 volts is going to guarantee you that you're going to have consistent capture of the myocardium. So the sixth acronym in the PBL stop is observation. And in the observation, like you can see in this place that I have highlighted right now, you're able to see any kind of monitoring that the device has had. It could be an arrhythmia, it could be atrial fibrillation, atrial tachycardia, it could be a ventricular arrhythmia, it could be patient activity, it could be optival fluid accumulation, which I'm going to have a look at. It could be any kind of observation that the device has had that it's going to highlight. And based on this, you're able to know what you need to go and look out for in the in the information in the cardiac compass and in the rate histograms. And so at times, maybe when the patient comes, he's going to come and tell you that he's been experiencing certain symptoms. And then when you go to the observation window is when you now start correlating some of these symptoms to some of these monitored episodes. Let's say if a patient has had a shock, or the patient has had atrial fibrillation from a certain period of time, you're able to come and see from this observation the exact time and the exact date, and you're able even to get the EGM of this particular arrhythmia at this particular day. So for instance, in this case, this is a CRTD. You see that in observation window, we see that shocks were delivered and they were successful, 0 failed. You're able also to see that there's a possible optimal fluid accumulation. You're also able to see that there's a long ventricular sensing episode, which you don't want for a CRT patient. You want to achieve at least more than 90% by ventricular pacing, and able to see also the capture management has changed. And on this window also, you're also able to see any kind of arrhythmia that the patient has had. You're able to see that patient has had VT-VF, 1 episode, and treated with 2 shocks. You're able to see that patient also had some monitored episodes of VT and SVT. So some of the available diagnostics that you can do with our device is you're able to see the arrhythmias, exact arrhythmias that the patient had at what particular time. And you're able to see even the time interval. Let's say if it's a VT, you're able to see the time interval with the onset and the time interval between the QRSs, the RR interval. You're also able to see the percentage pacing. And in the cardiac compass, you're able to see both arrhythmias, optimal fluid status, which can guide you on the heart failure of your patient. So for instance, in this patient that had a VT-VF episode, if you click on this echelon on the treated echelon, it takes you to this window that shows you the VT episode. It shows you that They tried anti-tachycardia pacing 3 times. Then a shock was delivered of 35 joules, and the shock was successful after the shock, the patient went into his normal rhythm. You're able to see the date that this happened, the time, the duration of this arrhythmia, and both the atrial and ventricular rates at this time of the arrhythmia with an EGM. And to get this EGM, you click on this icon here where my cursor is right now. This is where you get to see the EGM. So this window allows you to see the episodes, the success of the therapies given, the duration, and all that. And it could guide you on medication. It could guide you also on the programming that you need to adjust on the device. Let's say on the event that it was not successful, you're able to know, or maybe it was successful, or maybe there was a monitored episode that you wish could have been treated. You're able to know how to adjust the programmed parameters. So you're able to see not just for VT, but you can see this is VT, this is ATAF episode, this is SVT, supraventricular tachycardia episode, and this is ventricular sensing episodes. Both monitored and treated. So in the cardiac compass, I'm going to show you where to locate the cardiac compass. It allows you to see the frequency of these arrhythmias, allows you to see the physical amount of physical activity of your patient. Is he sedentary? Is he someone that is working out 3-4 hours a week? You're able to see the therapies that the patient has had. You're able to see ventricular rate when the patient has atrial arrhythmias. You're also able to see what you call the heart failure trends, which is based on the optical fluid and the thoracic impedances. Just a minute. Yeah. So in this cardiac compass, you're able to see the last time that where my icon is. You're able to see the last time the patient was interrogated or the last time that the patient was programmed. P, the notation P is for programmed, the notation I is for interrogated, and then you're able to see any therapies that have any treatments that have been done for any arrhythmia. You're able to see ATAF burden of this patient. You're able to see the ventricular rates during the ATAF episode. Then you're able to see the patient activity. Is the patient physically active? You're able to see the average ventricular rate during the day and during the night. You're also able to see the percentage pacing, both atrial and ventricular percentage pacing during the day and during the night. And you're able to see the optical fluid accumulation. So the device is able to measure intrathoracic impedance based on the fluid accumulation when the patient has heart failure. So ideally, the programmed device is that you see where you have this line just between 40 and 80 is 60. So that is the ideal line that the patient should be, which is less than 60. So anytime the fluid, the impedance goes above that line, there's a spike in the optical fluid, and now you're going to get that as an observation in your quick look screen. And that's an indication. Now, when the optical fluid increases, like when there's accumulation of optical fluid, there's going to be a drop in the impedance. And when there's a drop in the impedance, so what the device does, it measures the impedance and is able to know, there's an algorithm that is able to estimate the optical fluid accumulation based on the thoracic impedance. So a decrease in impedance is going to suggest that there's possible congestion in the thoracic cavity, and it's going to be an indication of optical fluid accumulation. And that's how you get to know about all this optical fluid based on the thoracic impedance measured by the device. So after you've done with the observations, you've seen any arrhythmias that the patient has had, you've seen how the patient is tracking, any his patient activity, his heart failure progression, is he having any kind of pulmonary congestions or anything. You're able now to go and know how to adjust your program parameters appropriately. So this is a CRTD page. You're able to see the parameters that you can change for this device. So you notice there's a mode switch, lower rate, and all this, and the pacing, and this is where you're able to the detections and the therapies for your arrhythmias. And here you're able to see also there's some I'm sure for CRTs, adaptive by VNLV. I'll go in depth on how to make all these changes. But ideally, this is the first, when you click on the params, this is the first page that you land into. And in this page, the main things that you're able to change is the mode, pacing mode, the lower rates, upper tracking rate, and all that, and also the atrial and RV sensitivity. And in case now you need to change the outputs of atrial lead, RV lead, LV lead, you click on this pacing icon, and it's going to take you now to a different, it's going to open a different window that's going to allow you to do different changes. Sorry for that. So in case for the defibrillation, this allows you to program your detections and to program your therapies. So this is VF, fast VT via VF or VT. You can program that based on the doctor's preference, and the VT also. So most of the times, if the patient has had a Holter before, or the patient has had a loop recorder, you know what the onset, the time, the rate at which the patient gets his VF. You're able to customize this to that particular patient. And then you're able to come here and also program, let's say, the therapies you need for this patient. Maybe you want to start with, for let's say for VT, you want to try do some burst, more like antitachycardial pacing, then do a ramp, then do a mild shock of maybe 20 joules before escalating to 35 joules if the arrhythmia is not treated. This is where you get to program all that. And the detection, this, when you click on this icon, this allows you to adjust and I mean switch on some of the algorithms that are able to discriminate when you have an arrhythmia. So I'll go to this page where you're going to see, you want to make sure that by the time you're shocking a patient for VT or VF, that this patient has true VT. And so you want to cancel out possibility of it being SVT. You want to cancel out the possibility of it being an AF that is being conducted down. And you want to cancel out the possibility of it being a lead integrity issue. So here on the detection is where you come and program all those algorithms on. So after you're done with your programming, I'll show you a quick window that has all that. After you're done with your programming, you now come and print your final. It's going to have stored all those parameters that you've measured: the sensing, the threshold, the lead status, and then you come here and print the final report. It's going to also put into consideration the programmed changes. Yeah, so any question up to there before I go into CRT optimization? No questions? Okay, I think I'll proceed. So for a patient that has a CRT, you want to achieve some good biventricular pacing. And at times, maybe when a patient has atrial fibrillation that is being conducted, it might compromise the total percentage biventricular pacing that you have for your device. So for this, for our Medtronic devices, to be able to achieve more than 90% biventricular pacing, we have some algorithms that help us with that. And some of them is the atrial tracking recovery, ATR, the ventricular sense response, and the conducted AF response algorithm. So I start with the atrial tracking recovery. So this monitors loss of atrial tracking. So let's say in this strip, you notice that a PVC occurs. Sorry, my highlighter. So you're going to notice that a PVC occurs, and the moment the PVC occurs, the next atrial activity falls under the refractory period. And so, since the atrial activity falls under the refractory period, it's not going to trigger the AV interval. And if it doesn't trigger the AV interval, means that what's going to happen is after the atrial refractory, the next thing is going to be a ventricular sensitive event, since the AV interval that's going to trigger now pacing, biventricular pacing, is not triggered. So for this algorithm ATR, it looks for 8 intervals, 8 followed up intervals of lost atrial tracking. And on the 8th interval that you've lost this atrial tracking, the device is able to adjust its PVAP by reducing 50 milliseconds to see if you're able to adjust in such a way that the next atrial activity is going to fall outside the refractory period. And so if that happens, if that doesn't happen, the device is again going to minimize the PVAP again. Usually the PVAP is 400 milliseconds. It reduces by 350. In case there's still loss of atrial tracking, going to reduce again by 50 to 300 milliseconds. And after that, after able to unmask, after the atrial activity falls outside the refractory period, you're now able to trigger the AV interval, which is now going to result to a biventricular paced, like in this case. So this particular algorithm, it's on for most of the devices that came in after, I think, 2016, after the Viva devices. And to program it on, usually it's under parameters. Under parameters, there's a window that has the additional features or the arrhythmia interventions. So you click on the arrhythmia intervention and you make sure that, sorry, I think I put in the wrong image, but I'm going to show you how it's still under the same window for ATR. But for most of our devices, this comes in on status as default. So for patients that have atrial fibrillation, which is being conducted down to the ventricles, so we have the conducted AF response that allows for that it helps to achieve good by-V pacing in patients that have conducted atrial fibrillation. So what this algorithm does is that in the tracking mode, let's say DDT, where the patient is tracking the atrial activity, the ventricular activity, for any ventricular sensed event that happens within the AV interval, the device still paces, like doesn't, in normal dual chamber pacemaker, a sensed event is going to trigger a sensed AV. But in this case, you want, in as much as there's a sensed event, you want to pace so that you have a proper BIV. So what happens in conducted AF response is if you have a ventricular sensing episode during the AV interval, the device is still going to pace to be able to achieve good BIV. For non-tracking mode, let's say like when you have a device VVI or DDI, so the sensed event doesn't have to fall within the AV interval. So any sensed event, ventricular sensed event, is going to result into a biventricular paced event. So the other optimization is a ventricular sensed response, where the device paces BIV pacing or LV pacing in some devices that allow you to program CRT LV pacing alone. So the device paces even when you have a ventricular sensed event. Like in case a PVC comes in for a patient, the device is still going to pace BIV to achieve good BIV, to achieve good percentage, biventricular percentage pacing. And the pacing is completed within 4 milliseconds of the VS to make sure that you get the tissue before it gets into the refractory. So besides those algorithms, the Medtronic device allows you to adjust and program different vectors. Maybe on the event that you have diaphragmatic stimulation, or you realize that you still have a very broad QRS, you still have, like, it allows you to play around with different vectors to help achieve proper by V and maybe improve the patient. For patients with heart failure, if you want to get good outcomes, this device allows you to program different vectors to be able to achieve this. And you're going to have a look at the LV vectors that you can program for both the bipolar and quadripolar devices. We're also going to have a look at the VV delay that you can adjust in case you have a desynchrony between the right ventricle and the left ventricle. And also we're going to have a look at the AV delay and how it can, it's critical in optimizing CRT. So, the ideal position to have the LV lead usually at 3 o'clock. But at times you find that the target branch that you have is so close to the diaphragm or so close to the phrenic nerve that you end up having phrenic nerve stimulation or diaphragmatic stimulation. And in that case, you might need to go back and reposition your lead, or you might need to intervene through programming and change different vectors to be able to minimize, to reduce this phrenic nerve stimulation. So for high-power devices, this you're able to achieve these programmings that you see here: LV tip to RV coil, LV ring to RV coil, LV tip to LV ring, LV ring to LV tip. So in case you have, let's say, in case you have diaphragmatic stimulation in program LV tip to LV ring, able to change and maybe use the ring to RV coil and see if it's still going to have diaphragmatic stimulation. Most of the time, might not have, or you might be having stimulation when passing through the ring. And so if that's the case, you may need to try and change and adjust to tip to RV coil. So for high power, you don't have an option to pace to CAN, but for low power, which is the CRTP, you can program a device LV tip to RV ring, LV tip to CAN, LV ring to RV ring, LV ring to CAN, LV tip to LV ring. Whichever of these programming that's going to give you the desired output that you need. So for these low power devices, again, usually it's not in all instances that you get the RV ring programming on. Like you've seen in this case, there's a red circle on any RV ring programming. This is because most of the times we have the left ventricular capture management programmed on in our devices. And when you have these on, there's usually a risk of anodal stimulation when you use the RV ring as your cathode. But irrespective of that, you still have the tip to CAN, ring to CAN, LV tip to LV ring, or LV ring to LV tip as your programmable options. So for quadripolar devices, this one gives you a variety of options. You have 16 pacing vectors. So this one, if in case you have diaphragmatic stimulation in 2 of your pacing vectors, you have a whole range of other vectors that you can use to program and pace. So besides changing vectors, the other thing that you can use to achieve good CRT is VV optimization. Let's say in an instance that you realize that after a pacing spike is initiated in the LV, there's a huge desynchrony between the RV and the LV. You realize one ventricle is contracting quickly than the other. So from your echo, you're able to see which ventricle, which chamber is contracting before the other. And with that, you're able to come and adjust the programmed parameters in the Medtronic device to either pace the RV first, the right ventricle first before pacing the LV first. And besides choosing which chamber to start, you're also able to specify the time interval in terms of milliseconds that you need to separate the pacing impulses in both the RV and the LV. So this is the VV delay. Here you're able to program the time interval, and it allows you to program between 0 to 80 milliseconds. And at the same time, our device has an algorithm that allows you to, that can test and tell you that the CardioSync algorithm that allows you to test and see what's the possible VV delay, what's the AV delay of your patient, and you're able to customize your programmings to this particular patient. But the best, I think, the recommended, the best approach for achieving synchrony is through what do you call echo optimization. So the last optimization that I'm going to cover today is AV. So there are two phases for ventricular filling, the passive phase and the active phase. So the AV delay can be too short and not allow for proper filling of the ventricles. So you want to program an AV delay that is going to allow proper filling of the ventricle so that you have a good ejection from your ventricle. And so you want to optimize and ensure that the AV delay is not too long or is not too short to allow proper ventricular filling and proper ejection of blood from the ventricles. And this is in the same window as where you get to change the V pacing and the VV delay. And the paced AV and the ST AV, sensed AV and the paced AV, you're able to adjust on the same window. Yeah, thank you. I don't know whether I'm going to be able to present, to show my